All right, good evening, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. Tonight, I am talking about Meniere's disease, and I'm hoping with this broadcast to give you a little more clarity on how to talk to your doctors about diagnosing your condition if you do not have a completely straightforward case. I am going to review a few of the other underlying causes that I feel that are not commonly talked about, that I've talked about in a lot of other videos through the years discussing Meniere's disease, but I'll go over those as well and give you some generalized understanding of the condition. And so I hope this is helpful. I hope this can give you some future directions, topics for discourse with your doctors, so that you can have the best treatment done for you going forward. So without further ado, this is the title of the broadcast. So I just always like to put that in there. There are my credentials. Let's bring this one in. So the symptoms of Meniere's are interesting because they're not always textbook. So classically, if you read online or as doctors are trained, the classic presentation of Meniere's disease is one where there's going to be fullness in the ear, there's going to be ringing in the ear, and typically associated with vertigo. The vertigo of Meniere's is different from other types of vertigo in that it's typically going to last for 2 to 4 hours and oftentimes associated with vomiting. So if you know someone who has vertigo, for example, and they lay down in bed and they have vertigo, but it lasts for like a minute, but then they feel off for the rest of the day, that's more something like BPPV. If someone has vertigo and they have a horrible headache and they're slurring their speech, we oftentimes are going to think, okay, they have like a hematoma in their brain. Maybe they're having a stroke. So Meniere's disease has the vertigo, oftentimes associated with nausea and vomiting. It's miserable to have vertigo for that long. But typically it's going to resolve in a matter of hours, although some patients can have it for prolonged periods. So that's the generality of Meniere's relative to vertigo. Now, the reality is that not everyone presents the same, and this creates a ton of diagnostic confusion in all actuality for a lot of doctors. You're having these symptoms, you go to your doctor and they have 10 minutes to kind of discern, do you have BPPV? Do you have vestibular neuritis? Do you have vestibular migraines? Do you have Meniere's disease? And just know that about 41% of Meniere's cases present with the vertigo I described, but that leaves around 60% to present with other types of features. Some Meniere's patients present mainly with auditory features. So they may have hyperacusis and ringing in their ear and maybe hearing loss. They may present with just more of the vertiginous symptoms. They may present with a mixture of the symptoms. And there may be the concomitant association of headaches, which then brings in a lot of confusion whether this is a vestibular migraine or is it Meniere's disease. Because vestibular migraines basically are characterized by headaches, but they're not usually like a migraine headache like you would associate them to be. There may be a history of migraine headaches. And with vestibular migraines, there's this headache, there's light sensitivity, there's sound sensitivity, but vertigo or an illusion of motion is the most prominent symptom, but there can be some auditory symptoms too. So hopefully from this, you're getting that like it's this milieu, it's this overlap. As I've termed it in other videos, it's like an overlapping Venn diagram. We learned in school like those little circles that overlap. So in this diagram, I'm just trying to show that, an individual can have no symptoms. They can have ringing in their ears. They may have hearing loss. They may have vertigo. They may have oral fullness, but they may not have all of these features in the beginning. And it may take 5 to 10 years of having vertigo attacks until the other features start to present. So if you feel like you're an outlier, know that you're not alone. And it can take time to really solidify a Meniere's diagnosis. I'm going to talk about imaging in this broadcast to hopefully also show you what the newest information is demonstrating for Meniere's patients. Okay, there may be a loss of balance, as I mentioned, nausea and vomiting. A small percentage, but it is a significant number of Meniere's patients have drop attacks. I think it's 72% will have mild drop attacks, and around 6% have these really severe drop attacks called the Tumorkin's autolytic crises, where an individual literally feels like they're being pushed down to the floor. So that's another symptom of Meniere's disease. All right, I'm gonna hide that one. I'm gonna show this one. Just to get a better understanding of the physiology, Meniere's disease is also commonly synonymous with a condition called endolymphatic hydrops. Endolymphatic hydrops is not 100% just specific to Meniere's disease, but most cases, Meniere's disease basically has endolymphatic hydrops. What do we mean by that? The endolymph is this fluid inside of your vestibular system and your cochlea where we hear things. The cochlea, as you can see, looks like a conch shell. So that's why it's called the cochlea. Now, as you can see in the right of the diagram here, that the endolymphatic hydrops demonstrates swelling of this endolymphatic space. And it's thought to be due to lack of drainage primarily of something called the endolymphatic duct and sac. And so for whatever reason in Meniere's disease patients, this duct is not draining the fluid, so the fluid is swelling back into the inner ear, potentially creating damage to the hearing organ or the balance organ of your inner ear. In terms of causation, as I've talked about in other broadcasts, 57% of Meniere's patients have been found to have a gluten allergy. Dietary allergies to dairy have been hypothesized by doctors for a long period of time. Food allergies are demonstrated throughout the literature to be more prevalent with Meniere's cases, and autoimmune disorders are much more common in Meniere's patients than other conditions. So it's thought that this swelling in the inner ear may represent the body's response to an allergic or autoimmune disorder, such that the allergic inflammation or the autoimmune inflammation somehow may be not allowing that duct that drains the endolymphatic fluid out of the inner ear. And as a consequence, the inner ear swells, and then we can develop damage to these organs, the balance organ or the hearing organ. And we also know from MRI scanning that a person may have damage to their cochlea and their vestibular system, but they present mainly with vertigo, or vice versa. They may have damage to both, and they present mainly with hearing symptoms and not vertigo. So not everything completely lines up, but this is an evolving process as we learn more and more about Meniere's disease. If you want to read more about autoimmune disorders, particularly thyroid disorders, autoimmune disorders to the thyroid, there's a great author by the name of Chiarella who's done a lot of research connecting causation of Meniere's disease and other inner ear disorders to thyroid disorders and autoimmunity. So I recommend you check that out. Now, I think this is cool for you to see. This is from, actually, let me do it this way. You can see the citation there. Let's do it this way. You may be able to read the citation from Nature Reviews. Nonetheless, yeah, we're going to keep doing that. Sorry for switching around so many times. This is probably the direction diagnosis of Meniere's disease is going to go to in terms of imaging of the inner ear. Now, before these imaging revelations came about, and actually what is still done in standard practice, is that if a person is presenting with Meniere's-like symptoms, and maybe vertigo, maybe low-tone hearing loss, maybe the pressure in the ear associated with ringing, maybe a mixture, all or some of those symptoms, and a doctor is, and good evening to everyone who's joining, and a doctor is suspecting that this individual has Meniere's disease, typically the next step is that they're going to be referred to an audiologist. The audiologist is going to then do what's called a VNG examination, standing for video nystagmography, where we put goggles on the face and we can video record the eye movements and tell what is going on in the inner ear and the brainstem with this technique. Now, as many of you will have had, typically in this VNG testing, we do a caloric examination where we inject warm and cold air into the ear, trying to create a convection current within the vestibular system. Let me hide this one. I'll go back to my other diagram if I can. Where'd it go? Here we go. So these are the semicircular canals, and basically the horizontal semicircular canal is activated when we inject warm or cold air into the ear. And as a result, the eyes will start to move reflexively as though you're turning your head. And we can quantify that and say, okay, well, the inner ear is working properly or it's not working properly on one side or another. And because warm air creates a convection current in one direction and cold air creates a convection current in another direction, we can then with a lot of certainty determine, is it the inner ear or is it a brainstem problem? So that's the typical examination, as well as then hearing testing, audiometry, typically done by an audiologist. We do these types of exams, particularly VNG in our office, to help solidify the diagnosis for Meniere's patients. Nonetheless, that's typically what is being done out there. And as I mentioned, as I'll keep going through, again, everyone can present differently. So 3 Tesla MRIs, or a very powerful type of MRI. The 3 Tesla magnet is a more powerful magnet than the 1.5 Tesla magnets, which are so commonly utilized in healthcare today. So 3 Teslas are kind of new, and so 3 Tesla, and I love the comments that are coming up. 3 Tesla MRIs are newer, so to speak. And so some imaging facilities have all 3 Tesla MRIs. Some imaging facilities may have 20% of their MRIs are 3 Tesla. Other imaging facilities are completely still 1.5 Tesla. Now, when they first started doing these studies, they would inject a contrast dye through the tympanic membrane, your eardrum. And then they would do this imaging, and from this imaging, they could see if there is swelling of the endolymphatic space. And that's what you're looking at here in the black. So these little arrows are pointing to black areas, which represent swelling. So one could look at the degree of swelling of the endolymphatic space, right to left. Keep in mind that about 30% of Meniere's patients are going to have a bilateral presentation at some point in their disease. So MRI scanning has greatly evolved to help us. Now, the sad thing is that most imaging facilities are not doing this yet. So I'm talking about this because I think the more patients talk to their doctors about it, the more we can get the ball rolling for this to be commonly clinically employed around the world. And know that there are studies coming out showing that 1.5 Tesla MRI scans can do the same thing. They just have to do some other imaging techniques. And so if you're interested in that documentation, I can send you the research articles. It's kind of really new stuff coming out, but it's exciting because potentially I'm hoping in the next few years that this type of imaging will be routine for Meniere's patients, because I will say in my clinical experience, I see so many Meniere's patients who, frankly, their doctors aren't really certain of the diagnosis. Sometimes it's very clear cut. Sometimes it's, it looks like Meniere's. We think it's Meniere's. And interestingly, if you're not responding to the standard treatment for Meniere's disease, the higher level treatments are going to involve something like cutting the vestibular nerve or injecting gentamicin, an antibiotic, into basically the inner ear to try and kill these structures so they don't send abnormal signals. Keep in mind that with this endolymphatic hydrops process, the inner ear is swelling. It's swelling, it's going through degrees of swelling. And probably when you're having a Meniere's attack, there is more swelling. And the confusing part for the brainstem is that this inner ear may be discharging way more at times and less at other times. So it's hard for the brain to compensate. So that's why the medical solution, and it's not a horrible solution, it's just a significant solution, so to speak, is that, you know, the easiest thing to do is to go in and cut out literally portions of the inner ear, or to cut the nerves from like the vestibular system, particularly because that's the vertigo is the most disabling symptom. So they cut the vestibular nerve, and then the brain is left to compensate, and hopefully it compensates. And if it doesn't, then a person may have significant symptoms going forward. So that's the MRI scanning. So again, if you want the research articles on 1.5 Tesla scanning, I'd be happy to point you in the right direction. But that's basically where I think a lot of you atypical Meniere's presentation cases are probably going to go in the future for a solid diagnosis. Now, let me hide that. I'm going to show this in stream. So basically, here you can see exactly what I'm talking about. We have definite Meniere's disease. And you can see that the primary feature here is this box that says EH confirmed, endolymphatic hydrops. So it's kind of like, I'm not going to be surprised if in 10 years it gets to the point where if you present with these types of symptoms, vertigo 2 to 4 hours, or pressure in your ear and ringing, or low tone hearing loss, and maybe some pressure, hyperacusis, meaning you're really sensitive to sounds in one ear, that the first step is actually going to probably be to do an MRI before we even do a VNG and audiometry. That's just my forecast. I'm putting it out there. So maybe in 10 years I'll be right. But basically you can see that that's really what these authors are kind of getting at, in that you may have definite Meniere's symptoms. It's confirmed via MRI. Probable Meniere's symptoms confirmed via MRI. Episodic vertigo of the Meniere type without documented hearing loss, other causes excluded. Then you're diagnosed with vestibular Meniere's if there's the swelling in your inner ear. Sensory neural hearing loss, fluctuating or fixed with disequilibrium, but without definitive episodes, other causes excluded. And I have seen this presentation. So if you have this hearing loss and then you're just kind of off balance, in the past, doctors would probably be really reluctant to diagnose you with Meniere's, but we now know that can be a presentation of Meniere's. And for some people, they don't have rotational vertigo, but they have this disequilibrium. The reason being, it seems that, I'll exit out of this, bring this one in. It seems to be that the inferior portion of the inner ear is most vulnerable to the swelling of the endolymphatic hydrops. And you can see here, there's a structure called the saccule. The saccule is more associated with linear acceleration, not angular movements. And the cochlea is down in this inferior portion. And basically, what they find is that some individuals mainly have damage with the endolymphatic hydrops process to the saccule and the cochlea. So because of that, that type of individual may present more with hearing loss and disequilibrium. So we can now say with MRI scanning, hey, actually you have Meniere's disease. It's an atypical presentation. And then we have cochlear Meniere's, where fluctuating and sensory neural hearing loss without vertigo, other causes excluded. Again, in the past, that would have been a slim diagnosis, but now we can really solidify that with newer technology. So the medical model, as many of you know, will be to, let me see if I can find the medical model slide. Here we go. Medical model is going to be mainly medications for nausea, benzos, also salt reduction. So hydrochlorothiazide is one of the most common medications that doctors go to flush salt out of the body. low salt diets, anything they can do to kind of keep the pressure out of the inner ear. Also, intratympanic cortisone or prednisone types of administrations can be done, have shown some efficacy. Again, if all that doesn't work and you're going to vestibular therapy and you're taking the diuretics and you're on a low salt diet and you have some sort of benzo for treating the acute vestibular symptoms, then that's when doctors start running out of options. And I see this a lot of the time. So they may say, you know what, we may need to we may need to decompress the endolymphatic sac. That surgery has come under scrutiny. As some people say it's effective, some people say it's not. So again, that duct that drains the inner ear, they try to go out and cut out part of the temporal bone, giving a person more space for that duct to drain the fluid. Or they do an ablation. Like I mentioned, ablation means cutting a nerve. So they may go in and cut the vestibular nerve. Problem with that is that there's no coming back from it if it doesn't work. And then behind that, the functional model. Functional model is really looking, in my experiences, I oftentimes tell my Meniere's patients, a lot of the time it is a dietary allergic problem or an autoimmune problem. And most autoimmune issues have some basis in gastrointestinal health, intestinal permeability, microbiome alterations, things of that nature. So first thing I do when I look at a Meniere's patient is I'm talking to them about their diet. I'm running panels for food allergies. I'm talking to them about gluten. I'm also talking to them about salt. And that is where my focus is. Certainly stress management, evaluation of their thyroid in a really acute way. Sometimes the medical management of thyroid conditions is way out here, and functionally we really try to zero in and get that thyroid working as best as we possibly can within the functional guidelines. And I think that's largely it. So again, think of your inner ear anytime you're having these symptoms. I hope this has been of some benefit to you. Really look into MRI scanning of the inner ear if you have a case of Meniere's disease that's not quite definitive. I also recommend you look into dissociation of food allergies and autoimmunity to Meniere's disease. And particularly if you're an individual who you think you have Meniere's, but you also have headaches, I think this presentation may be of some benefit. So again, thank you all for joining that watched this in its entirety, and have a great night. And I will be back probably next week with another broadcast.